this is a really practically orientated part of the presentation. This is menopause and how to do it, with a couple of cases as illustration. So want to go through indications and contraindications, and just remind you that there are less contraindications than there are with a synthetic estrogen like a birth control pill. Okay, practicalities of prescribing, a couple of clinical cases just to illustrate some very basic common garden management strategies. But the concern is that the very straightforward patients are being referred for specialist management and starting of MHT. And want to summarise the 2019 position on how to use hormones. So just to remind you, and you notice I'm using the terminology MHT, menopausal hormone therapy. So this is the PC term for HRT, and it covers all estrogen, progesterone, vaginal estrogen. Okay, so that's what MHT stands for. It is the most effective treatment. So you have to ask yourself very clearly, why would you be offering your patient who has significant symptoms and whose quality of life's been affected and who can't, her work productivity, her family life's been affected, why are you prescribing something else first line? And I'm saying that because that's clearly what's happening, at least, we're seeing patients from all around the North Island, and that's what's happening. And so and I think it's fear. I think it's patients' fear. There is not been education in the medical profession and a short consultation, and perhaps I'm going to be a little bit challenging here and say perhaps it's easier to say no than it is to say yes. So I hope to change your mind on that. Just to remind you, as Megan said, that for healthy symptomatic women who are within 10 years of menopause or under the age of 60, and that is the majority of women you'll see, and women who have symptoms. So this is not anti-aging. So if someone comes in because she's got a toy boy partner, she is worried about, they've been talking at the book club and they're worried about getting wrinkles and they just feel that they're sort of wrinkling up, I just give them advice to go and see some of the cosmetic people. There's plenty of other things. This is not the indication. But if the women have symptoms, and we're largely talking about vasomotor symptoms, but also a lot of psychological overtones, this is the effective treatment. You can individualise treatment, so it's not one size fits all, and particularly when you're thinking about a patient's health history, their family history, and their individual risks, you can individualise treatment to potentially make it even safer than it is already. And I think this is really important, this study, which got almost no publicity, that there is no increase in death rate from cancer, from heart disease, or from stroke using menopausal hormones. I don't think our patients know that. I don't actually think most of the medical profession know that. So the consensus from this study, this WHO study, which I think has probably been one of the worst things that's happened to women's health for the last decade or so. I really think that has disadvantaged women enormously. It's been re-evaluated. We have 16 years of post-extension study data. We've looked at the way the study was presented to media and to the medical profession, and as I say, there were many, many errors in the way it was presented. And we can say that if you appropriately prescribe hormones to healthy women within that 10-year window, it works. I mean, women are just in general joyful at getting their life back. There are very few risks, and possibly, and you note we've been conservative, so you might get a talk from the cardiologist or the gynecologist that says this is definitely primary prevention. I think we don't quite have that data, but certainly it's not going to risk their cardiovascular health, and it may in fact be a positive step. So this concept of the balanced view of menopausal hormones, and if you are not, and there's no one in your practice who's knowledgeable about this and able to prescribe this, you need to change the way you're thinking and make sure that this moves on. So indications for therapy, significant symptoms, and that are affecting quality of life and the way a woman is functioning in her everyday life, which may be her family life, her work, but can have very major effects on productivity. And always, as with anything that we do, you weigh up treatment benefits versus risks. But that statement from Joanne Manson, who was the lead investigator on the WHO, and I think, I'm afraid, being very cynical, she has been single-handedly responsible for an awful lot of women having a really miserable time, perhaps an awful lot of families and men having a very miserable time with their wives, and now she turns around and says, well, we're underutilising hormones and overstating the risks. So I think an apology, slightly stronger statement is in order. As endocrinologists, we think this is very effective, and it's certainly an indication for thinking about prevention and management of osteoporosis. So if you've got a woman who's under 60 who's otherwise healthy, it's not just about thinking about bisphosphonates. Hormones are an option. And I think, again, because it's a slightly longer discussion, it's not offered as much as it should be. And like Megan, I would be treating a woman with POI who presents to me under the age of 50, and certainly increasingly women in their 40s, with estrogen. I discuss it with a woman, we go through the pros and cons, but I would certainly be offering it to her if she was agreeable for the reasons that we've stated, not just immediate symptoms, but her longer term health. Contraindications. So as I said, they're rather more limited than with the synthetic estrogens in the birth control pill. So undiagnosed bleeding, past history of stroke, heart attack, or blood clot. And you note I say relative contraindications, but again, it's probably a little bit easier in the specialist setting to make that call than it is in primary care. So that's just a comment there. Someone who has had an estrogen-dependent tumour. Hypertension is not a contraindication, but you want to have their blood pressure under control before you start, and perhaps active liver disease. And there are situations where we would prefer to use a transdermal estrogen rather than an oral estrogen, and that would be particularly in a woman who's got focal migraine. So you notice focal migraine is not a contraindication. In fact, migraines often get worse with perimenopause and get better with estrogen, but I would offer transdermal therapy, and in some of those other settings too. All right, let's start with Cherie, who's 48, and she's a human resources manager. She's healthy, she still has her uterus. No doubt the consultation's so much easier when the patient's actually had a hysterectomy. She's slim, she's had irregular periods for 12 months, so there's certainly a suggestion at 48 that she's perimenopausal. And just a comment, we wouldn't routinely do an FSH, because she's over 45, she's likely to be perimenopausal. You might do the FSH if she was younger and you were uncertain what was going on. She can't sleep, she's not functioning, she feels dispirited, and she comes to you and she says, please doctor, I just can't work, you have to do something for me. This is one of my patients, and I just want to show you the response she got. And I wouldn't want you to think we don't have competent primary care in Auckland. So her first GP, her own GP, says, well, Cherie, you're just the same age as me. We're getting older together. Okay, it's part of life. This is actually a very straightforward woman who'd had very little to do with the medical profession, but she's so miserable she goes and sees her friend's GP, who says, nothing to worry about, you won't feel like this for long. And you remember Megan said the mean duration of symptoms is nearly 8 years. We used to say to you 4 years, it's actually now 8 from the SWAN study. So, okay, just take life a little bit easier. Now, she's a 48-year-old with children and a full-time job and probably lots of community service. It's not that easy. And the third GP she consults wants to give her a script for an antidepressant. Okay, now that's a real-life case that was just a few months ago. And that's the concern, is what's happening in primary care. Now, I put it to you, she's got significant symptoms, she's perfectly healthy, there are no contraindications, she is an ideal candidate. Why did none of these doctors offer her an effective treatment? And you really do have to ask yourself, if you're not offering an effective treatment, why not? And are prejudices getting in the road? Now, Cherie is rather keen for you to give her some treatment, but of course she has a friend. And remember my comment that we are often not the people who are influencing our patients in terms of medical advice or science. So her friend says that her GP won't use hormones because they cause breast cancer. And again, you've heard from Megan that in fact, if there is an increased risk, it's extremely small. So I think we've really covered that, but just to say that we've overstated the risk, that the additional chance of breast cancer, we believe, if it indeed is increased, and it wasn't increased in the WHI, is one additional breast cancer per 1,200 women treated per year. And in fact, that's actually less than being sedentary and overweight and having your glass or two of alcohol at night, which many of our patients do. You may be able to make that risk even smaller if you use natural progesterone, which we call Utrogestin in New Zealand, which unfortunately PHARMAC do not subsidise, or use a Mirena. Remember, if you've had a hysterectomy and you only need estrogen, so you don't need a progesterone to protect your endometrium, there was no increase in risk. That data came out in 2004 and just passed completely under the radar. So again, there's a differential in the consultation, and the hysterectomized women do not need to be concerned. And we think that it is reasonable to offer it in the women who are BRCA positive who haven't had a breast cancer, and there seems to be no difference in the women with a family history. Okay, so we've gone through that and we've talked about differential risks. The most recent data actually on VTE would suggest that transdermal estrogen does not increase VTE risk at all. Okay, so that's actually a preference on that. Now, Cherie you've counselled her and she's thought about what her friends said, but she's happy to start her hormones. And this is now how to do hormones. And I think, again, because there's been no teaching, and particularly the younger graduates, there's no experience in how to do this. So just to go over this very quickly with you. First of all, estrogen is what's going to sort out the symptoms, okay? And if you've got a uterus, you must add an effective progesterone. And I was pretty horrified at Goodfellow recently that people came up to me and didn't quite seem to understand that. So you need a progesterone if you have a uterus. And how you do the progesterone regime depends on whether you want periods or not and where they are in this menopausal transition. So if a patient has not had periods for more than a year, she's not going to be keen to want them again, and you can give her a continuous regime, but always warn that there could be a little bit of unscheduled bleeding to begin with. Get people psyched up for any possible consequences so they don't stop it, prematurely. If a patient is within a year of having their last period, so they're still menstruating, even if it's quite irregular, we would tend to give them a sequential regime, which is 12 days of one or other of the progestins, and have a scheduled bleed, rather than having unscheduled bleeding all over the time. You can then choose whether you want tablets, whether you want patches. Remember, unfortunately in New Zealand, we don't have a funded combination patch. So if you live across the ditch, you have more choices than we do here. And do you want oral or transdermal estrogen? Do you want sort of gold standard, or do you want convenience? So you can have everything all in one. You can have several funded tablets. You can have oral, transdermal. We don't have a funded estrogen gel here, but that it is available but not funded. That's funded in Australia as well. So there are decisions around, and my suggestion would be is you don't have to know all the various combinations. That's something for us to know, but you do have to have a few working combinations for the everyday patient that you see and be familiar with them. So gold standard. So I then talk it over with the patient. What are their goals and preferences? I'm certainly doing more gold standard starts than I would have even a couple of years ago, and that would be a transdermal estrogen, and it would be micronized natural progesterone, and we now have that available. It's called Utrogestin, but it is not fully funded. And the cost to the patient for the natural progesterone tablets, which they take at night because they get a little bit of extra benefit from sedation and sleep, is around about the $28 to $35 a month. Okay, so getting more buy-in with that than I perhaps was. The patch, thanks to PHARMAC, is now, I hope you're all aware of that, we do have a fully funded patch which you put on twice a week. Remember, a lot of us used Climara, which was once a week, and I'm still getting patients who have been transitioned to Estradot, but it's only been given once a week, and it needs to be given twice a week. Okay, so fully funded. If costs are an issue for a patient, then Proganova, so an oral estrogen, and Provera or norethisterone are fully funded, but you've got a 2-tablet rather than a 1-tablet regime. Some patients want everything in the 1 tablet, so we've got combination partially funded tablets like trisequins if it's a period one, or no period one would be something like Cliavance or Cliagest, and then estrogen only, so you've got funded oral or transdermal estrogen if you've had a hysterectomy. Make sense? Yeah. So again, just having a few regimes that you know about, the dose range, and a really good site to look at these is the Australasian Menopause Society. It's got a very clear table that Megan and I have actually printed out in our protocol books, and it tells you how much progesterone and what sort of progesterones you can use to oppose what doses of estrogen. So rather than dwell on that today, let's move on. Now, maximise efficiency and minimise problems. So again, I think first of all, not forcing a patient to start hormones if they don't feel comfortable. So there is science, and then there's our gut feeling. So again, I think that discussion, taking the time to discuss with the patient, and this is not a consultation you can do in 10 minutes. Okay, this is definitely something that you're going to get some health checks and you're going to bring the patient back and just, manage it so that there's time and education. So what does the patient want? They're always worried about putting on weight. And just like with a birth control pill, there is no weight gain with hormones. All right? Next thing is unscheduled bleeding and breast tenderness. Relatively uncommon, but just to be aware of it, it almost certainly settles down. I tell patients it's like being a teenager again, so that they need that, kit that, we perhaps advise our daughters when they get close to puberty, carry around a little bit of a kit and not to wear white trousers or white skirts for the first few months that they take their hormones. I tend to start with low dose. Now, again, that's variable. If you've got a really symptomatic patient and you start with low dose and you don't get control of the symptoms, they may lose a bit of faith. So again, discussing with patients whether they want to just get straight on to something like 1 milligram of oral estrogen or 50 microgram patch, which would be about average, or they want to start lower because they've previously had breast tenderness with, say a birth control pill or something. And then review the patient at 12 weeks and allow the patient to adjust the dose in between if they want to. Now, contraception. I put this slide in because I gave a talk at the Australian Menopause Society, and that was something that people wanted to focus a little bit more on, what to do about contraception in this setting. So this is and I mentioned that earlier in the morning, the rule of thumb. Contraception for 2 years if the last menstrual period is under 50, and for 1 year if they're over 50. Again, depends on the patient's sort of perception of risk. I must admit, as a practicing endocrinologist, I'm not getting too worried about contraception when a patient gets into their later 40s. But it depends, again, on their view. So that's what we suggest. And if you use the Mirena, which is very good endometrial protection, or Depo-Provera, which is also endometrial protection, you've got progesterone and you've got endometrial protection and contraception in one hit. And we do not consider there is data to support using mini pills, Jadel, Cerazette, yeah. There is no firm data that is sufficient for endometrial protection. It's a great pity that when we were looking at long-acting progesterone devices, that the Jadel was the one that was funded rather than the Mirena, for not just here but in the PCOS setting. Yeah, okay. So she comes back. So you have talked to her. She's indicated she's keen about hormones. You've sent her off for her health checks. She doesn't need more mammograms, but she does need to have. You'd like to have a breast exam or a mammogram before you started. She's updated her smear. She wants an oral regime. She likes tablets and she wants not to pay extra, so she starts on Proganova, 1 milligram a day. And remember, she was still getting some periods, I think, so she's going to have a sequential regime of the Provera for 12 days a month, and I've said why. And then we see her for 12 weeks, and she is just thrilled with you. You are very popular. She has her life back. You check that her weight hasn't changed, her blood pressure is normal. She's happy with the menstrual cycle she's getting on this regime. She's got no breast tenderness. Now, she needs contraception. And she's feeling a bit anxious that she absolutely doesn't want another baby at this stage. And so at that point, you have a chat with her about whether a Mirena might be a good thing. But especially having established with her that she likes estrogen and she wants to continue. I wouldn't put a Mirena in first off, because you might have done all of that and the patient may not want to continue for some reason. And then follow-up, it used to be said 6 monthly, and we're so confident about this that follow-up can actually go out to 1 year. All right. Now, International Menopause Society recommendations on monitoring, and we think we've covered that. You don't have to do extra mammograms, but you do need to use a patient as their own bioassay. So keeping an eye on their health and what's happening in the family in case it might influence their benefit-risk profile. So that's, I guess, what we're saying for that. And use the opportunity. Cardiovascular disease is what's going to kill your postmenopausal woman. So this is a great chance again in primary care to think about health as someone goes forward. Exercise, smoking status, mental health, having, if you like, a heart-friendly lifestyle. So the same PCOS advice can apply to your postmenopausal woman. Now let's move on to Kathleen. So she's 61, okay, and you notice that age, okay, because everyone's flooding in at 60 being told that by their GP that they have to come off their hormones. She's been on her Cliovance and she's taken it for 8 years. She had awful vasomotor symptoms, and she knows that if she tries to wean or she misses her tablets, these symptoms come back. Okay, we've said that's not so surprising. But her general practitioner has said, you're 60, you've got to come off it. And so she's sent in to see the specialist, and she doesn't want to do that. Okay, what's the data? And what do we say in clinical practice? Now, we've said that it's very common to have persistent symptoms, and I think we have to be prepared to manage it. If 20% of women still have vasomotor symptoms in their 60s and 70s, it's not something you can ignore. All right. We know that if a woman starts estrogen later in life and further past the menopause, we know that's the thing, I guess, that WHI showed us, that the risks are a bit greater. But this is not the case. She started at an appropriate age in her early 50s, and the question is, can she continue? So it's really a discussion between you and her. How severe are her symptoms? Has anything happened to her health that would influence the decision? Could you give her, does she really want to be on hormones? Could you make the hormone situation safer by altering what she's taking? Remember, she's on an oral combination technique. Could she have some of the alternatives that are available? And I'm just going to show you those very briefly. So that's a question between, and I find that my patients are actually pretty clear on what they want to do, but I think that's an important discussion to document and to keep having at regular intervals. So what does the North American Menopause Society say, continuing, and you notice that they say continuing after 65, so that's an even older group. Individualise, don't stop simply because of an age or duration of therapy. And of course those, I don't know where those rules crept in, but they've sort of crept in and they seem to be in the collective consciousness. So lose the idea you must stop because you've been on it for 5 years, you must stop because you've reached 60. Individualise, discuss, look at the patient and her health. Jointly make the decision, and their comment is, provided you have talked to a woman, and really we actually don't have the data for the woman who starts at 50 and goes to 85. You know, there are many physicians in this area who would say start and don't stop. So I think, you know, it's an individual decision, but it's not an absolute no just because she's reached a certain duration of therapy or an age. And this is where you might choose to individualise. So let's say she wants to stay on hormones, and you might discuss with her, this might be the time to move to transdermal therapy. As she gets older, she has more risk of stroke and VTE. So you can reduce that risk by a different route of administration. You might be able to drop the dose. You might find that she doesn't actually need 1 milligram of estrogen. She might get away with 0.5 milligram of estrogen, and that might have less risks. If she's only on estrogen, we've got a better situation anyway. And the other issue is the progesterone. She was on Cliovance, so she's having a norethindrone regime. So this might be the chance to move her to transdermal therapy, perhaps lower dose, and ask her if she was prepared to pay for natural progesterone, which we believe data is still sort of coming in that area, but most of us in the area would believe that that's safer, particularly in terms of the breast. Now, let's say she said she's prepared to look at other options. She's not wedded to her hormones, but she wants to look at something else. Now, what I want to point out with this slide really is that all of us discuss, I'm sure, many of these options that you can see on the slide, all right? And in fact, many of them have absolutely no data to support them. So again, comes back to it behoves us to know whether we're suggesting an option for our patient that is supported by the data, and not just willy-nilly use our own biases and preferences. So level 1, which you would actually recommend, look at all those lifestyle changes which don't actually seem to work, but we all talk about, CBT, and interestingly, hypnosis. And I guess that means that finding a good hypnotherapist and having a relationship with them, but they are the level 1, and actually things like relaxation and paced respiration don't seem to work. There's not much to be had from altering your diet. There's been a lot of supplements and herbal therapies, and basically there is no evidence. And people pay a lot of money for them. They're better to spend the money perhaps on getting a personal trainer and, joining the gym. We know that there is a modest benefit from the serotonin reuptake inhibitors. And again, on the Australian Menopause website, there's examples of doses and sometimes one might have to try more than one. We know that gabapentin also works. And clonidine, I guess by the time anyone comes to me, I've never seen anyone do very well on clonidine, but there is very modest evidence that a transdermal patch of clonidine may be very modestly effective. Is anyone in the room wedded to clonidine or had a lot of uptake or benefit? Yes, I guess the trouble is by the time I see someone, they've failed everything else. So that's probably the least effective of these options and wouldn't be your first choice. And there are some other things. Interestingly, acupuncture doesn't seem to work, but lots of our patients try it. Stellate ganglion block is offered by the radiologist in Christchurch. And it's actually very effective. You block the sympathetic chain in the neck. And so that's something for patients who've perhaps had breast cancer or the older patient who's got persistent flushes. It doesn't seem to be offered anywhere else in the country or in Australia, but it has benefit. And going to the chiropractor, unfortunately, doesn't seem to be particularly beneficial either. Now, these are the dosing regimes, and you can look them up. As I say, none head-to-head work as well as estrogen, but there are situations that you would be keen to avoid estrogen, as we've discussed. Bioidentical hormones. Now, depending on time, we could just about sum up the bioidentical talk in this one slide. And this is a statement from the US Endocrine Society, and there are many professional bodies, and you could, like we do, have something printed out in your room rather than use the whole consultation to talk about it, give it to patients to read, and then they can come back to and ask questions. But basically, there is no data that suggests that the so-called bioidenticals are actually safe or that they work. There's no regulatory oversight of any of these aspects. So it's just completely, it's unknown hormone therapy that's unmonitored and has no data. And if what the patient wants is natural treatment, or the more correct term is not bioidentical but body identical, remember that's exactly what we're offering in our natural oral or transdermal estrogen or in the natural progesterone. And people look quite surprised. I mean, even my local pharmacist, who's really good, told one of my POI patients when I prescribed her natural estrogen that it was synthetic. And she didn't tell me this, and she just waited for 6 months for her follow-up appointment and didn't take it. So I went and offered him a talk, the group a talk on this. So just remember where incorrect information can come from. Now, back to Kathleen then. So she has a discussion about potential risks. She's been offered non-hormone option, she's been offered CBT, and perhaps we might even offer her hypnosis, and she doesn't want to go down that path. She wants to stay on her hormones. And so then we look at individualizing it for the safer gold standard regime, continue to monitor, continue to reassess. Okay? And remember, this is a patient who's got continued symptoms. So this is not just willy-nilly staying on it. This is because someone's symptomatic when they're not on it. Now let's move to Akiko, who's 47. So she's younger than Kathleen. She's a part-time beautician. She's got 3 teenagers. She's got perimenopausal symptoms in that her periods are irregular and she's got hot flushes. And it's not really that brings her in, it's her libido. Get a lot of referrals to the endocrinologist, and I'm sure to you, about libido. And she's got discomfort during intercourse and dyspareunia, and she's actually really quite upset about this. And she's worried about where this will take her in her relationship. And just, again, this is not a quick discussion. There are a lot of things that affect libido and sexual function, and what I often say to patients, and men in the room might object to this, but I say if you think about the sort of Venn diagram, for men it's 3/4 hormones, and that's why men might use prostitutes. But for women, most of the factors that influence libido are actually not their hormones. So a history is really important. Is this a long-standing, is something else going on, or is this loss of libido really just happened as a patient became peri or postmenopausal? So I think for a female there are many, many influences, probably more than we know, and it's not just a jump to the conclusion that it all must be your hormones and therefore a quick fix. And it's not, unfortunately, related to testosterone. And one of our colleagues had a article in Next which was not reviewed before it got published, and we're just getting, you probably are too, truckloads of patients coming in believing that they need some testosterone to sort their libido. Okay, strategies to manage sexual difficulties, and you see that I talk about some lifestyle things, and this is actually very real, that the vaginal mucosa is actually healthier if you're having intercourse than if you're not having intercourse. Understand the difference between lubricants, which is for sexual intercourse, moisturizers, which are an alternative to vaginal estrogen. Remember that if the problem with your libido is that you just don't get any sleep because you're waking multiple times at night with hot flushes, getting some more sleep will do the trick. And this is probably within the specialist realm and does not involve the compounding pharmacist providing some very active testosterone. We find this really helpful, and again, we're very fortunate to have really high quality urogyne physiotherapists to look at the pelvic floor, and very helpful psychologists who can look at the supratentorial factors, which may well be having a major part to play. I think the psychologist fixes more disorders of sexual function than I do with my hormones, actually. Right. When to refer, and again, what I want to say to you is I'm hoping after this discussion this afternoon that confidence is restored. Most of these patients do not need a specialist. Okay, so the people who might need to come is someone who's got classical symptoms, might be the normal age, but has got a complicated past medical history that makes you feel uneasy. And it's not that we might say anything different from you, but you've just had two people supporting whatever the decision is. For instance, a woman who's already had a clot or had a breast cancer and whatever. The woman who has somehow skipped through and has got into her 60s or 70s and still has awful symptoms and finally fronts up for a discussion. That's obviously is going to be a more difficult patient. Someone who things just don't work with your usual regimes. And there are going to be a small handful of patients who are progestin sensitive or have lots of bleeding. The person who has persistent symptoms, and of course I think POI patients probably all should see a specialist endocrinologist, because it's just there's so much of a multidisciplinary approach, a complicated workup, as you've heard from Megan, and follow up. I think, if possible, that would be appropriate. So what have we learnt? We've learnt that it's a clinical diagnosis, opportunity to have preventative health strategies. Keep in mind what you're treating and what you're not treating. So again, patients' view of hormones may be the anti-aging route, and that's not what we're using it for. But also, as I say, don't overstate the risks and understate the benefits. You can be very reassuring that in healthy women, 60 or under, within 10 years of menopause, risks are extremely small, and in the right woman with significant symptoms, benefits are significant. And again, just some websites for you to have a look at. Australian Menopause Society is fantastic for you and fantastic for patients, and very few people seem to be using that as a resource.